Okay, well, it is 8 o'clock and we have a lot to talk about this morning, so we are going to go and get started. First of all, I want to thank everyone for being here this morning for our monthly ABIN webinar. We're so glad you could join us. This is a quick reminder that this webinar is being recorded. By staying on today's call, you are giving us your permission to record this. We will be posting this to the ABIN website. I'm going to do a bit of a formal introduction and then a warmer welcome. So today we have with us Dr. Virna Little. She's the co-founder of Concert Health, and the co-founder of Zero Overdose. She is an internationally known speaker for her work in integrating primary care and behavioral health, developing sustainable integrated delivery systems, and suicide prevention. Dr. Little is an expert in CoCM and provides technical assistance to organizations and to states across the country, integrating primary care and behavioral health. She's been recognized with awards from the Society for Social Work Leaders in Healthcare, National Association of Social Workers, Community Health Center of New York, and others. And I am so pleased to have Virna here today with us. Virna has been working with Arkansas and with ABIN for a long time. She has been a friend and partner. She has spoken at our conference, and we know many of you may have heard her. But what I know Virna best for is she is such a passionate advocate, always willing to help and talk about CoCM. I remember when I was trying to get more information about Virna and sat down at a lunch with her, and you explained things in a way that was so clear, so understanding, and just amazing. Virna has been working in the behavioral health care space her entire career, and she's also assisted with really providing some advocacy support to our own CoCM work group that we have here in Arkansas, as well as support with current legislation that's been introduced. So without further ado, I'm going to turn it over to our friend Virna Little to present today on CoCM.
Well, thank you. That was a warm welcome. Much appreciated. And it's great colleagues like Patty and Kim at ABIN that make the work fun. So thank you. So good morning, everyone. We are going to spend the next hour or so talking about collaborative care. So there's a wide group of people on the call. So I'm going to try to be able to sort of fold in. One of the things that I've been able to perfect over the past couple of years is multitasking. And so I actively watch the chat while we're going along. So feel free to unmute and ask questions. We'll also take some questions at the end, but also feel absolutely free to put questions or thoughts in the chat, and I can take them and answer them as I go along, or, I can stop, or I'll know they're there and can answer them at the end. So feel free to do that as well. So I always just like to talk a little bit about the history. So collaborative care actually started as a research trial, late 90s, early 2000s. It was then called IMPACT, or Improving Mood Promoting Access to Collaborative Treatment, started by a psychiatrist who actually used to go and work in primary care and thought, boy, this is kind of a mess. There's got to be a better way to do this. And so they did a randomized controlled trial with over 1,800 patients, 400 primary care providers. At that time, they used nurses as care managers, and it was really focused on depression. That was successful. I actually had the privilege of replicating it for the first time in the real world in New York City, in NORCs, or naturally occurring retirement communities. It has since then morphed into collaborative care, what we all sort of affectionately call collaborative care. And it is well supported now. It seems like every time I turn around, there's another trial. So it's now well over 100 randomized controlled trials that say it works. So we know it works, right? Like we can sort of put that aside. We absolutely know collaborative care works. We also have learned a lot about collaborative care in underserved populations. I'm actually just putting something in a rural health journal around outcomes in our rural health centers and rural health populations, which is the FQHCs and RHCs are certainly a passion of mine, have spent many years working with them. So also some research out there in women's health, outcomes in women's health and outcomes in other places. So if you have questions about very specific populations, I can answer them. I can send research, or I can sort of talk to you about what I've seen in the data. So I know that Kim mentioned advocacy. We are absolutely doing some advocacy. I see a couple of folks from other states here, so just talk a little bit about where we are now. So of course, it has been a Medicare benefit since 2017 with very dedicated CPT codes. We are now up to 24 states that have Medicaid on the fee schedule. Unfortunately, they're a little over the map. There's only a few states that have done something different around underserved populations. Unfortunately, Arkansas made the decision to exclude the Medicaid population, but did pass the codes, and then Montana passed the codes but excluded the FQHC. So those are probably the two states. So we still have some advocacy to do. All of the commercial plans are covering collaborative care, and that depends on what your commercial contracts are. So whatever percentage of Medicare your commercial contracts are, or what you're going to get paid for the collaborative care codes, but have not had a problem with the commercial plans, and glad to talk about specific ones. And some of the payers like United, like the Blues, have been incredible partners. Just giving them a shout out because I know they're on the call. Incredible partners, giving data, sharing information, helping with advocacy, covering the codes. So many of them have really been friends in the collaborative care effort. And of course, Medicare Advantage and the Medicare Advantage plans. For a while, Humana was waiving copays. That's since stopped. But the Medicare Advantage, of course, has been very supported. So I want to just be really clear and level set so that we all know collaborative care, because I think there's still a misconception. Well, you know, I was actually in Montana this past weekend talking to a center, and they said, we don't need this. We collaborate all day long. And I said, yeah, that's great. But really, collaborative care is a very specific model that has very specific requirements. And so when we think about collaborative care, we actually add 2 people to the primary care, pediatric, women's health team. So the first person that we add is a collaborative care clinician, behavioral health care manager, whatever you choose to call them. They are generally a master's prepared person, although CMS has said that they don't have to be licensed. Generally, some states say that they have to be licensed, others don't. Generally, it's a master's prepared person. And this person really works closely with the primary care, women's health, pediatric provider in whatever organization we are. We were recently working with this organization, and the patient. And the nice thing about collaborative care is that it is truly patient-centered. Because it is a monthly case rate and not by the contact or by the session, that means that as a clinician, I'm a psychologist and social worker by trade, I have the ability to talk to that patient every day. And I know that, you know, my friends from AFSP are on the line, and this is why I really feel like it's important for people at risk for suicide, because I can talk to them every day, do a DBT skill, a safety plan. So very, very patient-centered over the course of a month. What really works for the patient is going to be helpful, and then reinforcing. So very, very interactive with that patient. The second person that gets added to the team is a psychiatric consultant. This psychiatric consultant can be an MD. They can also be a psychiatric nurse practitioner, as an example. So this psychiatric consultant really complements the team in that they meet with that collaborative care clinician, behavioral health care manager every single week. And they talk about people that aren't getting better or are getting worse. And when we talk about getting better or getting worse, we use some tools to measure. Because what collaborative care is really putting a system in place to track populations of patients with behavioral health needs. So for depression and anxiety, as an example, for depression, we would use the PHQ-9, for anxiety, the GAD-7, and really look for a 50% or 10-point decrease in those scores in the first 90 days of treatment, and then continue to monitor to 120 days of treatment. Most individuals are in collaborative care for about 6 to 8 months. And this psychiatric consultant will then say, okay, let's talk about the people who got worse by more than 2 points, who haven't gotten better by more than 2 points in a period of time, people that are having side effects, people that might be at risk. And then they make recommendations in the electronic health record to that primary care, women's health, or pediatric provider. And that can be recommendations on starting or adding or changing medications, around a lab value, around something else, around a comorbid condition, or other information, over-the-counter medications or substances. And so really giving them information and supporting them, and also being available to them for consultation. One of the important pieces also and components of collaborative care is a registry, and the registry is super important. Most electronic health records don't meet the requirement for a collaborative care registry. Epic does, MedEnd does, some of them are getting there. There are some registries available from like the AIMS Center, the Care Management Tracking System. There's an Excel sheet that's available. There's some other external systems that meet the requirements. But the important part of a registry is that it helps us track a population. And that's probably one of the biggest pieces that it's hard oftentimes to get organizations to really think about. How do we manage our population of patients with behavioral health needs, our patients with depression, like we track our diabetics, right? That we have a registry, we know who's getting better. And even for our FQHCs and RHCs who have a UDS measure for depression outcome, don't seem to really have put systems in place to really track in some very proactive way their patients with depression. So this is incredibly helpful for them. And oftentimes, it's really hard for providers to get the idea of patient being parts of populations and really putting everybody in collaborative care, as opposed to just individual patients that they might feel need like counseling or something. So this is the collaborative care model, adding these two people to the care team, using a registry and being very specific. And so when we think about what some of the roles are, the primary care, women's health, or pediatric provider, they're still sort of captain of the ship, right? They're the ones that are overseeing the patient. So they're often the ones that first see the patients, because we know people come to their trusted primary care provider and talk to them first about maybe having difficulty sleeping or how anxious they've been feeling. So really saying, okay, this person, I really do think they have anxiety. They're going to need some care and treatment and some support. They're prescribing medications, first and second line medications. They're doing a warm handoff. There's a big misconception around warm handoffs. One is that every patient needs a warm handoff, which is not true, right? When we send, asthmatics to pulmonologists, we don't do warm handoff to pulmonologists, right? We make the referral and then people go. So some people really benefit from a warm handoff like that in person. Other patients don't need that. We also some thoughts about virtual or remote collaborative care, which we'll talk more about. Because collaborative care, a good portion of it was actually remote and telephonic right from the beginning, from the research trial, way before it was fashionable with COVID and all of that. And we'll sort of talk about why that is. But being able to do a warm handoff that says, hey, I work with Virna. She's part of my team. She helps me care for my patients who are anxious. I'm going to have her give you a call later today. Actually works really nice. So oftentimes people get stuck and I have to have this in-person warm handoff. And that actually is often not a deal breaker. So working with the collaborative care clinician, that psychiatric consultant, and that care manager is really doing medication adherence, really following up, using evidence-based practices. Because even though collaborative care in and of itself is evidence-based, like as an umbrella, we still use all of the evidence-based treatments that we know still work for individuals who are struggling with depression and anxiety as examples. And so one of the things that we will do is use sometimes all of those during the course of collaborative care. And then, of course, that psychiatric consultant is going to make recommendations. One of the more common questions that I get is, does that psychiatric consultant have to work for the organization? The answer is no, you can contract with someone. The other is that one thing I will tell you is a deal breaker, and it's a safety issue really, is that they have to have access to the electronic health record. They absolutely be able to see the last provider's notes, the medication list, the diagnosis list, to look at labs, all of that. It really isn't safe to do psychiatric consultation unless that psychiatric consultant has access to the electronic health record and then can document directly, which is both a liability and a quality issue, absolutely document directly back into that record so that it's there, and then also so that the primary care provider can see it. So there's a question around what type of individuals are the best behavioral health care managers. So I think there's a couple of really important pieces. Does this person have to be licensed? No, they do not. However, they do need to be able to provide the treatment choices that we're going to talk about, one of which is talk treatment. And so really it is a little bit of a better fit for a master's person, but that doesn't mean I've seen wonderful nurses. RNs are amazing behavioral health care managers. I've also seen, some bachelor's level folks really do nice work as care managers. So it depends. The most important thing when thinking about your first hire is this has to be someone who is really able to be out and about in the mix, working with the providers, not going to be hidden in an office, but they're going to be out. This is the person that you say to them, we don't actually have a place for you to sit. And they go, oh, okay, cool. This is the person that, can bounce into visits before or after primary care providers. This is the person who could sell you the car you didn't think you needed. This is the person who can really super engage patients. So the right person trained up is probably the best idea for a practice just starting out. LMSWs just coming out of school are fine. Sometimes LCSWs are a little more. You don't necessarily need an LCSW. They don't have to be an independently licensed LMHC, LCSW person. And it also depends a little bit on your pro forma, quite frankly. In Arkansas, where Medicaid, so I know I've got some FQHCs, RHCs, where Medicaid doesn't cover the codes, which is a large percentage of your population, you may actually have to do some independent billing as part of your pro forma. And then you're going to need to hire a provider that can do some independent billing so you can get your PPS rate and make your collaborative care services at least be self-sustaining. But glad to answer more specific questions about that, but hopefully that was helpful for you, Adam. So when we think about the core principles of collaborative care, these to me are some of the most important. I've talked about patient-centered. This truly, to me, is patient-centered. Lots of places or services say that they're patient-centered. To me, collaborative care really embraces patient-centeredness because people can change through the treatment choices that we'll talk about. It can change, the cadence can change, the time frame, the duration can change. And it's really what I think is helpful for me as the patient. And so incredibly helpful. Also, really patience in crisis. So one of the things about collaborative care, because it is that monthly case rate, again, people who are in crisis, you can give them that extra support. And one of the things that we've learned about collaborative care that really makes a difference in both engagement and outcomes is not the amount of time that you spend with a patient, but the number of contacts that they have. And I've seen that over and over again. It's well researched. I've seen it over and over again in data. So it's really helpful to support people that might be in crisis. Very population based. And this is a big shift for a lot of practices because providers are so used to just having one option. Oh, there's a behavioral health need. I'm going to send you to counseling or therapy, or I'm going to send you to psychiatry. And so one of the things is to really get people to understand that there's a broad spectrum of people with behavioral health needs. And when you think about your entire population, right, I always tell people divide your population up into buckets. So you have your health and behavior needs, you've got collaborative care, your non-collaborative care population, and folks with some acute, more chronic mental illnesses. And so your collaborative care bucket is a pretty substantial group of people, and they have very varying needs, just like your population of diabetics. Some people need a dietitian, diabetes care manager, they need groups, they need all kinds of help, they need frequent visits, they need insulin. And other folks just need, a little bit of information, and then they're good to go. And so same with your patients with depression and anxiety, you want to make sure they're getting the right touch for what they need. And collaborative care allows you to do that, but only if the providers really embrace this idea of caring for your entire population. Otherwise, what happens is you just continue to get the people that they think still need like counseling, and not really get the broader population. Also very, very treat to target, feeling very strongly about getting those outcomes and reducing the symptoms. Because if you think about it, if somebody's been sad for a long time and I reduce 50% of their symptoms, how much that changes their daily experience. I mean, it's absolutely tremendously life-changing for people. And so very treat to target and changing things up all the time. If you're not getting better, we're doing something different. If you're still not getting better, we're doing something different. We're going to continue to really make sure that we're actively changing up treatment to really proactively get those symptoms reduced. We're accountable to the entire population. And again, we're using evidence-based treatments. And so a lot of times people will ask me, well, collaborative care really isn't treatment. And I say, well, it absolutely is, because as a clinician, I'm a psychologist and a social worker in collaborative care. I use cognitive behavioral therapy. I use dialectical behavioral therapy. I use problem-solving treatment, motivational interviewing, behavioral activation, sometimes rational emotive, right? I use all of those as I need them. Right? I pull them out of my tool belt during the times that I'm talking to someone. And the thing about collaborative care is because it's so patient-centered and so proactive that no patient has the same schedule. Sometimes I'll go into a practice and they say, we do collaborative care. And I say, well, let me see the schedule for your behavioral health care manager. And if I see people scheduled at a regular cadence every week, every other week, once a month, whatever it happens to be, I know they're not doing collaborative care. Because every patient should be a little bit different and it should change over time. I should talk to you maybe 2 or 3 times a week in the first month, and then it should change as we move towards just really making sure to monitor your symptoms and we're doing some relapse prevention, and that it should change all the time. And so really bringing in those evidence-based practices. So when I talk to someone, maybe I'm talking to them for 10 minutes to follow up. Maybe I'm replacing a cognition. I'm using some motivational interviewing. So I'm using all of those evidence-based practices to care for that person. And while collaborative care is short-term by design, 6 to 8 months, but quite frankly, even if I saw someone in a community mental health center and I'm really focusing on their symptoms of anxiety as an example, that's about what it would take me to help reduce someone's symptoms. And so I often don't say it's short term, because it's actually, we're just going to get you better. And that's kind of really where we want to stay. So this is my favorite piece about collaborative care, is that there are choices, right, for treatment. And the thing about these choices is that they can change from week to week. So there is medication adherence. So to really help you, it's really difficult to take medications every day. And so tell me about the times when you're not able to take your meds or when you don't take them as prescribed, right? Because the minute we ask people, so are you taking your medications? Oh, yes, of course. They asked me the other day in my primary care visit, and I said yes. And that was totally not true because I'd been on the road for 3 days and not taken my lisinopril, right? And so really asking questions and then engaging people around medication adherence, right? And that could be talking to you every day or every couple of days and really trying to figure that out. Behavioral activation, this is absolutely my favorite. I use it all the time. And one of the things that I love about it is you see people get better so quickly. What's something you can do today or tomorrow to help you feel less sad? And my rule is that if it's before lunch, I say today. If it's after lunch, I say today or tomorrow. And then we set a small goal, right? Maybe it's that you're gonna call your son so that he can get a chair out of the basement. And then we're gonna make sure we get that chair onto the porch. And then we're gonna maybe have you sit outside. So very, very small goals. And I'm calling you every day or other day to really follow up. And I have seen people really change dramatically their symptoms. So maybe we set a goal of opening. I've had patients that haven't opened their window blinds for a long time. And so we're going to open a window blind. What do we see outside? How does the room look different with the light coming in? And then maybe the goals, we're going to sit by the open window blind and have our coffee the next morning. How did that go? What did you see? And then maybe we open the other windows and imagine that light is coming into your house for the first time in a long time, how that changes your mood, what it does, and that you've been able to accomplish a goal. So that's really the spirit behind behavioral activation. And I use behavioral activation a lot. The other is talk treatment. So in other words, counseling, talk treatment, maybe every week or every other week. The misconception oftentimes about this treatment choice in collaborative care is that once you're in it, then you're in it like you are in counseling every week or every other week for a period of time. I can say to you, you know what, Kim, you've got a lot going on. Maybe we could set a time next week to talk a little bit longer. And then Kim would be in talk treatment, but maybe just for that week. And so these are really, really flexible. And the last is symptom monitoring. I often use symptom monitoring when, I've been my most engaging, endearing self and somebody says like, meh, I'm not really having you, right? And then I will say, it's really important that we know how well you're doing. We have a way to measure now your emotions, like we measure your blood pressure or your sugar. And I really want to be able to keep your provider in the loop. Is it okay if I just give you a call every week or every other week just to ask you some questions and see how you're doing? So that symptom monitoring, and of course, am I going to chat them up? Then absolutely. And oftentimes then they'll go into behavioral activation, right? And it's not like I'm saying, oh, here are all your choices. I kind of just roll into them. But these treatment choices can change from week to week or month to month, really depending. And so understanding these treatment choices is really critical to collaborative care. This talks a little bit about what the journey is going through with that primary care provider still sort of being the head and then the patient going into collaborative care. So let's talk a little bit about what people are appropriate for collaborative care, because I think there is some confusion around patients that are appropriate. And so when we think about depression or anxiety, those are big umbrellas. Everybody under those umbrellas can go into collaborative care. Probably the most common question I get is, our patients have a history of trauma. And so they're probably not good collaborative care patients. They are absolutely wonderful collaborative care patients for a couple of reasons. One is because many people who go to treatment for PTSD, as an example, or histories of traumas, don't go and stay there. They don't tend to engage in care often. What we seek for collaborative care is because it's high touch. and it's symptom focused, that we actually do really well with patients with PTSD, because it gives them a sense of empowerment. It reduces their daily experiences around some of the PTSD symptoms. And then when they have a successful treatment outcome, they feel empowered. Then they can, if they want, go on to some more specific treatment like EMDR or exposure or something. And we can also use some evidence-based treatments for PTSD, like some exposure in collaborative care, maybe during a talk treatment session. And so they actually do incredibly well. And we do see higher rates of engagement for collaborative care than we do with traditional behavioral health referrals. So, you know, I've seen as high as 80 or 90% in practices where they do this really well, and the providers are really engaged and do that nice introduction. Alcohol and substance abuse, I've had so many people say to me, this was the first time somebody talked to me about how I was feeling and not just my drinking. So absolutely. And then, of course, any grief and bereavement. So there's a wide breadth of individuals who could actually go into collaborative care. Love it for the women's health and the pediatric populations. So talking a little bit about both of those, I have seen it be really successful in pediatric populations, generally like ages 6 and up. I think that for the 6 to 11-year-olds, the measurement-based care isn't as clear. And there's lots of conversations about sort of how to figure that out. New York and some other folks, New York has it more organized, but ADHD and using the Vanderbilt and looking for that 50% reduction in the Vanderbilt actually folds really nice into collaborative care. And so that's actually an option, and glad to talk a little bit more about that. And then also thinking about your 12 and up population, that's generally where a lot of practices will start, because the PHQ, the GAD are all evidence-based for that population. And adolescents do fabulous in collaborative care. Particularly, you see anxiety so prevalent now. Giving some coping skills, some progressive muscle relaxation, deep breathing, following it up. Oftentimes they don't need medications. They do really well in sort of those brief contacts. So when we think about implementing collaborative care, super important to get the primary care providers engaged. This is not a behavioral health initiative. This is a primary care initiative. Even the codes that we're going to talk about in a couple of minutes are primary care codes. And so really important to understand that it is impossible to really implement collaborative care with meaning without engaging the medical leadership. The chief medical officers, the senior medical leadership have to be on board. They have to have some consistent guidelines around first and second line medications for depression and anxiety. They have to really understand that this is a population health approach and it's a primary care initiative. We don't use words like therapy or program for collaborative care. Quite frankly, I never even say collaborative care. I just really roll, and putting in population health approaches. So some decision supports in your EMR. If I'm a nurse and somebody calls me for a refill on a depression or anxiety med, then we assess your symptoms. Are you 10 or above on the PHQ or GAD? If yes, you're going to collaborative care, so we can get a psychiatric consultation and we can do a care plan. So really making sure that the PCPs are really educated. Really making sure that that there's an understanding there. Also, really thinking about how you're going to launch collaborative care. Some of you here have multiple sites. Really thinking, where can we start? We maybe want to start in places that don't have a lot of support. We can hopefully, we don't have to hire somebody on site. We'll talk a little bit more about staffing, but remote behavioral health or collaborative care works fabulous. So you can do something right away for those sites. Where there's providers that are already sort of backed up. And I talked to a practice the other day and they had a big waiting list. I said, let's pull the people off with depression and anxiety. They can go right into collaborative care. I do so many implementations, not just with Concert, but externally. And they would, say, well, we kind of already, do this, but this is really allowing you to cover your entire population. And so really supporting women's health, pediatrics across the board. So a patient wouldn't be required to participate in collaborative care for refills, but it's kind of like, if there was a diabetic and they called for, their insulin, we want to just make sure, like, what is your sugar? Are we checking it? Do we know what it is? Have you been in? Very much the same kind of philosophy. And really making sure that we're supporting and including collaborative care in a lot of your organizational processes. So for referrals, also for transitions of care, doing PHQs and GADs, so that we're really paying attention. So oftentimes when we think about collaborative care in the population, most patients are being missed. And I hear this a lot from organizations, like, quite honestly, FQHCs, rural health centers say, we do this. We have a big behavioral health, we have behavioral health providers. We've been doing this. We're integrated. And I always say, yeah, you're doing a fabulous job. There's no question about that, really, having those services. But the reality is, if you were to run a report today of all the patients on depression or anxiety meds who have never touched behavioral health, have never had that initial 90791 as an example, CPT, you're going to get hundreds, if not thousands of patients. That's your collaborative care population. And so oftentimes what happens is we're just getting, I always say, the frosting on the cupcake, right? The people who have glaring behavioral health needs get referred, but the cupcake, right? The patient who's been on Lexapro for 3 years and we actually don't know how well they're doing, that's your collaborative care population. And that patient is not likely to touch behavioral health. So really thinking about what that looks like. And in order to really do this, you really have to have a population health approach. If you came to me and you said, Virna, we really want you to help us with our collaborative care implementation, and we're going to have the providers hand off to our behavioral health care manager, and I would say, and what else? That warm handoffs alone don't often make the sustainability for a collaborative care implementation. You need at least 2 population health approaches, a decision support, running some reports, some systemic approach, so that you can really capture your entire population. And that's really the big thing. And if you were going to ask me, what is the biggest mistake that practices make when implementing collaborative care? I would tell you they go to a place, and it is a cold, dark place that never ends. It is the land of perpetual launch. I have literally known practices that have been launching collaborative care for 10 years. And we know how to avoid that now. And I'm really clear about when you decide you want to do collaborative care, whether you decide to build it internally, do a hybrid, contract it out, doesn't matter, is that 30 patients for every care manager, 30 patients the first month, 60 patients the second month, 90 patients the third month. Most practices are self-sustaining at 60 days. And this does a couple of things. It gets the care manager in the groove of managing a population of patients, right? It gets the primary care providers understanding what collaborative care is. The billing people go, oh crap, we got to figure out this monthly billing thing because we got 30 patients and 60 are coming. And then it really gives you a full path to a full caseload by month 3. So we know that this actually saves money. We actually have some wonderful data from our friends in the Blue Plan from your state. Did a really nice write-up of cost savings, North Carolina, like we know. So for those of you that are thinking about value-based care in some contracts, we actually know that we see a cost saving. So let's talk a little bit about the codes. So for the FQHCs and rural health centers, CMS was not as kind as they could have been. And you have the G codes. They are the monthly 60 minutes. So you only get the G code, not as helpful. But for your commercial plans and hopefully someday for Medicaid, you'll be able to bill. But for Medicare, for practices that are not FQHCs or RHCs, the first month of collaborative care is 70 minutes. And that includes an assessment. And for our behavioral health folks on the line, this is not a full behavioral health psychosocial assessment. This is, how long have you been feeling sad? When haven't you been feeling sad? That's me doing a differential diagnosis. What's been helpful? What hasn't? Have you ever been in the emergency room or the hospital for feeling sad? Right. So it's a much lesser, what do I really need to know? Outreach and engaging patients. I'm going to call attention to this because in month 2, you notice you do not see that activity. So if I'm trying to get someone engaged in month 2 and I'm doing outreach phone calls, they don't count actually towards the time. And we'll talk about that a little bit more. Updating the registry, entering patients in the registry. That is an activity. Psychiatric consultation and any care that we do in person, video, or telephone all counts. So it's 70 minutes that first month. For those non-FQHCs and RHCs, as we're talking, remember that there is a 50+1 rule that can apply to your commercial and your Medicare plan. So it could be 36 minutes as an example for month 1. Month 2, 99493, the second CPT code, 60 minutes. A lot of the same activities there, minus that outreach and engagement. And then there is an add-on code, 99494, which is 30 minutes of additional time. Medicare does have something in their guidance then and caps the 99494 at 2. There are some commercial plans who follow that Medicare lead. There are some commercial plans like Aetna that do not and will pay for multiple 99494s. So you'll have to look at that a little bit. Generally, you may have a couple more 494s in the beginning of treatment, but it levels out. That's what we see. And then the last code is this general BHI code 99484. It is not technically a part of the collaborative care codes, although I like to think of it as the code of last resort. There's no 50+1 rule for it. It is 20 minutes. So if you have less than 20 minutes of care activity, you're kind of poop out of luck. There's not much you can do in terms of billing. But 20 minutes or more, you could bill this 99484. And so the thing about this code is also that it doesn't have to be billed by a primary care provider. It's one of the codes that a psychiatric provider could bill. Also, it can be more broadly applicable to some care coordination services. So sometimes people will use it for community health workers, you know, for some other coordination and care planning kinds of services. So I mentioned in a monthly case rate, these are the things that are included in the time. So psychiatric consultation, the thing about psychiatric consultation is if I talk to my psychiatric consultant and we talk about Kim, and yes, I'm picking on Kim today, I love her. So is that if we spend 10 minutes talking about Kim, is that 10 minutes only counts once. It doesn't count for me and it doesn't count for my psychiatric consultant. It's only 10 minutes. So generally the psychiatric consultant will be documenting in the electronic health record their consult. And I, the care manager, will be going in and saying patient discussed in psychiatric consultation, see separate note, time spent 10 minutes. We generally know that because these are monthly case rates, one of the best ways to do this in the electronic health records is one long-standing note for the entire month. And then I close it out in the end of the month. We're not cluttering up the charts for the providers and all the time is in one place. So discussions or case reviews with the primary care provider, I can certainly track that. And then of course the providers can add to their E&M codes or, you know, bill for that time as well, but separately. Updating my registry or keeping my registry, not documenting in my electronic health record. That's administrative. Telephonic work, any of the talk that I do with patients on the phone, absolutely. Discussions with collaterals, I'm explaining to someone's family member, we're setting a goal together where I'm talking to them about what some of the tools are. In-person visits, I put that here because some of you, if you have a high Medicaid population, may need to bill some of the visits under the psychotherapy codes in order to make your services sustainable. We want to make sure that we're documenting in the chart It's not documented, it's not done, and we want to use exact time. So every time I update the registry, I don't put 2 minutes, right? Then I'm actually looking. I have on my desk a clock, and I have a you know who there. I can't say her name because then she'll say something. I have it there to help me track the exact time, also because I like to see pictures of my grandkids. But I have it there and I just get in the habit of looking at it, right? People ask me all the time, what about metrics for collaborative care? The first thing that you want to not do to your care managers is put them on your regular productivity requirements. It totally stresses them out, and it's like fitting a square peg into a round hole. You want to actually look at what they're doing. So are 90% of my patients, my episodes for that month billable, right? Am I engaging patients? Am I effectively managing my caseload, right? And then also, am I then 90% of my time is attached to something billable for my episode? And do I have 90 patients, which is about the caseload that seems to be effective for people? So you can call those Virna's 390s, but that is actually helpful. So when you think about metrics, that's actually helpful. Oftentimes, if 90% of their episodes aren't billable, they're spending too much time with people, or they're not engaging people, and all of that is training in terms of how they start and talk to people. So I wanted to make sure that I left a couple minutes for questions. I know I've been kind of answering, but one of the things that I wanted to try to do just to help you conceptualize it a little bit better is what it actually looks like on the ground. And so if I were going to get someone referred to me today, I was going to call someone, I would say, I can see that you were in earlier today and you talked to nurse practitioner Smith, and you talked to her about how anxious you're feeling. Tell me a little bit about anxious. So it sounds to me like you've been feeling anxious for quite some time. Is there a time recently or in the past when you haven't felt anxious? Has something worked for you in the past that has helped you really feel less anxious? What kinds of things work for you? What hasn't worked for you? Have you tried something in the past that hasn't worked for you? So it sounds like the nurse practitioner offered you some medications, but you decided now that you might not be interested in medications, which is certainly fine. We find that a lot of people with anxiety can do really well, just understanding some things and recognizing what might be helpful for them. Is there something that you can think of that you might be able to do today that might help you feel less anxious? And then we would set a very small, manageable goal. And I'd say, I'd love to give you a call tomorrow and see how that went for you. And if the patient says yes, they are automatically in the goal setting treatment choice for collaborative care. Automatically, then now they're in collaborative care. I'm following up with them. If they say no, then I do say, listen, it's going to be really important. We know how well you're doing. I'd love to give you a call in a week or so, ask you some questions and see how well you're doing. I might also talk a little bit about, had someone the other day, and we talked about box breathing. It sounds to me like you get really anxious at work. Some people that I talk to find it really helpful to do some breathing. And then we watched a video together online about some box breathing and talked about it, right? So doing some interventions. I'd like to give you a call tomorrow to see how that went for you. And so that's what collaborative care will really look like. I didn't talk about treatment choices. I didn't talk about collaborative care. I didn't talk about, any of those pieces. And oftentimes when patients say, well, I need therapy, my provider told me I need therapy, I let people know, listen, we've learned a lot about getting people better. Like we've learned a lot about how to care for people better with cancer. We've learned a lot about how to get them better with anxiety. And we found that therapy is better in doses, like medication is better in doses. And so you're going to get a little dose of me, or you're going to get a little dose of treatment a couple of times a week. And so that's often how I do that. So there's some questions. Does this engager work with chronic care management? The answer is yes and no. If you're an RHC or an FQHC, the answer is no. If you're anywhere else, the answer is yes. People can be in chronic care management. Of course, this applies to Medicare, chronic care management, and collaborative care. So is there a copay for general BHI code? So the answer to that is yes. There is a copay for some of the commercial plans and also for Medicare. So there would be, and remember, because collaborative care is a monthly case rate, if I pay $20 to see my primary care provider, then it's going to be $20 for a month of collaborative care. So it makes care affordable and accessible for people, particularly with Medicare and commercial plans. So there is a copay for these services, the same as you would be for your primary care. So for Medicare, oftentimes it's about $36 a month as an example. Great questions. Thank you. And feel free to unmute. Feel free to put questions in the chat. Somebody just asked me privately about consent. Written consent is not actually required. They did that very briefly with chronic care management. It tanked miserably. There was like 9 patients enrolled around the country. And so they got rid of written consent, and it is verbal consent. It is documented. It's done by the primary care provider generally by virtue of the referral, and then documented again by the care manager is probably the most common workflow. We actually put some recommendations into CMS that, it can sort of really happen in either place. But glad to answer any other specific questions about your population or your practice or collaborative care in general. I know that was a lot of information.
You do such a fantastic job, Virna. We're so appreciative. But I want to reach out and ask our participants. This is our time to ask Virna, or Dr. Little, excuse me, about CoCM. And we're hearing from a lot of you that you're interested in CoCM, or you have specific questions. There may be barriers. And so want to give you an opportunity to ask any questions.
And there are opportunities, you can do a pro forma, build it internally. I can tell you what doesn't work. If you have behavioral health providers now and you say, oh, we really want to do collaborative care. So social worker in the clinic, you're going to do collaborative care now also, plus what you were doing, that never works. The times that has worked, literally in the probably 1,000 implementations that I've done, I could count on one hand the number of times that's actually been super successful. You really need someone dedicated to do this. Get a master's student, have them work themselves into a job. Somebody at least half-time doing this and doing nothing but this is actually the best way to go. If you're really just going to add it on to someone, I would tell you to wait or tell you to reach out. Let's figure out a pro forma and look at some other options.
That's helpful. I did have a comment from someone, and let me read. The question was, if you're doing, if you're peppering in pieces of talk therapy, do you have to have a license to bill that service? So as we talk, care manager may not be a licensed mental health provider. What are your thoughts on that and any workarounds?
So the treatment choice is talk treatment, right? Not talk therapy. And so there are some things that are in scope for somebody who's not licensed. So as an example, problem-solving treatment for primary care, very well used, very well researched. I've trained a ton of licensed and non-licensed providers, nurses to be able to do it. Works fabulous. Behavioral activation, motivational interviewing. Even for our patients at risk for suicide, doing a Columbia scale and a safety plan is in scope for them. So there are certainly lots of options, and also DBT skills, or CBT skills and not doing the therapy. So really thinking about how they're documenting and then what's in their job description would be my suggestion. Stacy, I see you have your hand up. Hopefully that answered the question.
Thank you.
Hi, yeah, I have a couple questions. So for the care manager, do you find that many are developing a schedule in their EMR so that they can schedule patients for specific calls? And just thinking about how that would then help the patient to have it identifiable, that it's almost like an appointment so that they're seeing it as a reminder. Do a lot of systems do that?
Yeah, it gets a little complicated then if you have that scheduled, and then it has to be like arrived and it doesn't, create some system problems. But yeah, absolutely, to be able to schedule a 15-minute follow-up or a check-in is absolutely appropriate. And so that's really a piece. And so I guess that would probably be up to the system, but generally having some scheduled, and also a lot of care managers will schedule people so that they remember to call them, as a reminder. So there's a comment in, as an LMSW working towards my LC, I think it's important the patient understand the person helping them may not be licensed. I think yes and no. If I were a student in training and providing treatment, then I think it's important to let you know ethically that I'm in training, right? Or that I'm not licensed. But if I'm a medical assistant, if I'm, someone, then it's not necessary for me to tell if I'm doing things that are in scope, right? I'm not doing anything that's not in scope. So there's a question here. An LCSW that can work part-time independent and part-time collaborative care. Can you speak to that, especially in the children's clinic where Medicaid is a large population? Yeah, honestly, you're probably going to need an LCSW or somebody licensed, because in order to be self-sustaining, given the Medicaid exclusion, you're going to have to probably build some of the like a 90832 psychotherapy codes in order to be self-sustaining. So based on your plans and your credentialing, probably an LCSW, unless you can build those codes for an LM in your setting, you're probably going to need to do that. Where can we find examples of the initial assessment? I actually have one that I can share. The way that I do it is I actually have something that has questions from the PHQ and the GAD on it, and then ask, so how long have you felt this way? Because what I want to do in that initial assessment, so let's just take the PHQ question around sleep, right? I'm also getting ready for my psychiatric consultation. So I want to know, well, do you fall asleep and not stay asleep? Right? Because that might be more depression. Are you not able to fall asleep? And that's the problem. So then I know a little bit, that helps me a little bit with the diagnosis. Then I can also give that information to my psychiatric consultant. And then I ask one question from the GAD, because I want to know, are you not sleeping because you're worried about something, right? And so it helps me take me through. So, and then the way that I also think about it, if somebody scores a 2 or a 3 on, let's say, the PHQ or the GAD, then I put that over in a care plan section, right? And then if it's a 0 or a 1, I put it over here in a relapse plan. I call it the things that work list. Because if I'm not having any trouble sleeping, well, a lot of people who are really anxious have trouble sleeping. Tell me what works for you, right? Are you doing something now that's been helping you sleep? Oh yeah, well, since I've been taking melatonin, I haven't had a problem, right? Oh good, so we're going to put melatonin over here in the things that work list. So in other words, on day 1, I'm doing my differential, I'm figuring out information that I need for my psychiatric consultation. I'm populating the things that we want to work on. You've told me that sleeping and concentrating are, where you're having the most difficulty. What's something you might do today or tomorrow to help you sleep better? And then over here, I've started our things that work list or a care plan. And so I have a guide that sort of helps talk you through all that. So I can certainly share that. No problem, Stacy. You can reach out to me. You know how to find me.
That's awesome. Thank you, Dr. Little. One question, and I know we're at time, but we do have some community mental health centers on. Have you seen this in reverse systems? So thinking about trying to do collaborative care in specialty behavioral health settings, and what has that looked like?
So I love the idea of doing measurement-based care in community mental health centers. The problem is billing the codes, because only primary care providers can actually bill the codes. And so for the 99484, a psychiatric provider can do it. Where there's organizations, mental health centers that have a primary care component, like a provider comes in a little bit, or you have some refers integration or CCBHCs, then what we've done is shifted all of the med management or med only patients over to the primary care provider. They've continued the medications. We put them in collaborative care that helps free some of the psychiatric resources, and then allows them to build the collaborative care codes. So that's a little bit, and a lot of the FQHCs who also have specialty mental health, we've done the same thing, and that allows them to expand their behavioral health resources as well.
What a succinct answer. Thank you. I was asking that with a minute left, so I appreciate that. I know it's 9:01. Any burning thoughts or questions? If not, we understand your time is extremely valuable. We want to thank you for being here today. Please reach out if you do have any questions. Dr. Little, thank you again so much for your time and your expertise. You are truly amazing. And
no problem. Feel free to reach out to me. I'll put my contact information in the chat again. And if you have questions, you want additional information, feel free to reach out to me, and I'd be glad to send it to you. And also, you know, certainly Kim and the folks at ABIN are experts as well.
oh, we appreciate that. Thank you. Thank you, guys. Have a wonderful day.
Thank you, everyone. Great day.